Hello, I'm Hansen. I'm a medical oncologist at the Princess Alexandra Hospital in Brisbane, and I'm here today at the ANZUP 2024 in the Gold Coast. And I'm joined by my esteemed colleague, Professor Ravi Kanesvaran, who has very kindly come to the Gold Coast and shared with us much of his expertise. And today we wanted to have a conversation around what he saw as some of the innovations coming in oncology. So firstly, Ravi, thank you so much for being here. Could you tell us a little bit about what you see as the innovations recently in bladder cancer?
Thanks, Aaron. And again, I want to thank you and Matt for inviting me over here to share some of my views and thoughts about bladder cancer, as well a bit about public policy and how cancer care is evolving in Asia. And pertaining to your question on bladder cancer, in my presentation, I focused on two main areas. It was muscle-invasive bladder cancer because we have a lot of data in the adjuvant space, as well as now new data that's probably going to come out in the next couple of months with greater detail in the perioperative space as well. So let's start with adjuvant immunotherapy. So that has been a bit of a breakthrough in the last few years. As I mentioned, there are three trials. Firstly, IMvigor10, then there was the Checkmate 274, and the Ambassador trial, right? All three trials had somewhat similar design. Basically, patients who had neoadjuvant chemotherapy, followed by radical cystectomy, and either were unfit for cisplatin-based chemotherapy or refused platinum-based chemotherapy. So then they were randomized to receive either immunotherapy, which could have been atezo if it was IMvigor trial, in Checkmate 274 was nivolumab, or pembrolizumab in the Ambassador study for a period of 1 year. Now, 2 out of the 3 studies were positive for disease-free survival benefit. However, we have not seen overall survival benefit yet. Nevertheless, disease-free survival meant fewer patients had relapse, right? And of course, we hope over time, one of these 2 studies may have an overall survival readout, which up to this point has not happened yet.
I was really curious about the data that you presented around ctDNA as well. Tell us a little bit more about that and where you see that fitting and where you see it going in the future.
So the ctDNA study was a post-hoc analysis from IMvigor10, and Tom Fowles and investigators had published and presented this over the last 2-3 years. I think the first study was really thought-provoking. Basically, they looked at patients' ctDNA at the point before they were randomized, and they found that it was obviously prognostic, right? So patients who were ctDNA positive did worse than ctDNA negative. Now, amongst the group of patients who were ctDNA positive, patients who had atezo seemed to have benefited significantly compared to those who were on the placebo arm. Now, this was important because subsequently, on further interrogation, he also found it to be a surrogate clinical endpoint as well, because he looked at ctDNA at cycle 1, day 1, before cycle 1, day 1, and at cycle 3. And what he found was patients who ctDNA positive and was converted to negative actually did better than patients who did not have a conversion of the ctDNA. So ctDNA essentially is a surrogate marker of minimal residual disease, and we have seen this across multiple tumor types that these patients are probably going to do worse and may benefit the most from additional adjuvant therapy, specifically with immune checkpoint inhibitors in this case. Hence, they have now moved on to IMvigor11, and I'm sure there's some sites in Australia recruiting for that trial. We have recruited some patients in Singapore as well, and that will give us, some certainty about this, method of selecting specific patients.
Could we transition a little bit now to the metastatic setting? Because you also presented some very powerful data there as well. Could you speak a little bit more about the newer treatments that have come in the metastatic setting for bladder cancer?
So over the last 2 years, there's been a whole buzz about antibody drug conjugates, right? And first of which in bladder cancer would be EV or enfortumab vedotin. Now, this is an antibody drug conjugate targeting Nectin-4. Now, initially, when these studies were designed, of course, the thought was maybe it's targeted perhaps to specific group of patients that highly express Nectin-4. Then, of course, we found out that most metastatic UC patients express high levels of Nectin-4. Hence, these studies were done on all MUC patients, and the outcome was astounding, right? And so presented at ASM last year, the data published in the journal this year, and clearly there was significant, and we're talking about a 50% or more reduction in mortality, with a hazard ratio of 0.47 and a progression-free survival, hazard ratio of 0.45, something we've not seen before, against standard of care chemotherapy. Of course, the argument was, this was probably not the best standard of care because most of our patients now who have responded would have gone on to get avelumab maintenance as part of the Javelin 100 study. But about a third of the patients did get avelumab, and even in that group, there was a benefit for EV. Hence, that's now the new standard of care.
The enfortumab data is really exciting, and ADCs in general seem to be really changing the treatment landscape of bladder cancer. Are there any other ADCs in bladder cancer that you're interested in?
So the first line approval was for EV and pembrolizumab, right? And the other two EVs in drug development right now, one is, I think a lot of GU oncologists are familiar with SG, right? Sacituzumab govitecan, and that has data after patients who have progressed on EV and multiple lines of chemotherapy and immuno. Now, we also have disitamab vedotin, which is anti-HER2 ADC. Now, with DV, which was developed in China, and now, of course, it's one of the drugs in the Pfizer pipeline. It's been combined with pembro, and prior to that, the study done in China was combined with another anti-PD-1 inhibitor, which was toripalimab, which is a Chinese PD-1 inhibitor. Now with pembro, and there's an ongoing phase 3 trial, so we're probably going to get data for that. But this is specific to groups of patients who exhibit HER2 expression of 1+ and above, IHC HER2 expression of 1+ and above. So again, not all MUC patients will benefit from this strategy.
I was also interested to hear your take on the FGFR story as well. Could you tell us a little bit more about where you see FGFR inhibitors and what seems to be happening there?
So it was very interesting when studies, at least the preclinical ones, showed that metastatic UC patients may have FGFR alterations, some fusions or mutations, and as such, drug development went down that path because there were FGFR inhibitors against FGFR2, 3, and these studies, however, at least the preclinical ones, showed that only about 15 to 20% of patients have these alterations. Hence, it may not apply to most. So 1 in 5 MUC patients may benefit from it. Now, in a phase 2 study done about 5 years ago, there was clearly a benefit for the use of FGFR inhibitors, specifically in these group of patients. However, the phase 3 took a bit of time, and a couple of years later, we have the TOR study, which is a phase 3 with 2 cohorts. Now, the first cohort were patients who had chemotherapy, immunotherapy, exhibited FGFR alterations, and received erdafitinib, and they benefited when compared to alternative chemotherapy. Now, the second one was cohort 2 was a bit more thought-provoking because the thinking would have been, this is a target, and we have a targetable drug to hit it. Usually, we'll anticipate pretty high responses. However, when compared to immunotherapy, which was cohort 2, which these patients were immunotherapy naive. They had chemotherapy, they were randomized to erdafitinib versus immunotherapy, and lo and behold, there was no overall survival benefit. So that was pretty surprising and to some extent disappointing because it didn't kind of meet what we expected out of that trial. But this did give us important information about how to sequence these drugs in the future.
Yeah, I think those are really powerful insights. But I wonder now if we could transition completely away from therapies and talk about what you were mentioning before about the work that you've been doing in terms of looking at gaps in care across the Asia-Pacific region. You shared some great data with us. Could you speak a little bit more to that?
So I did quite a bit of work as part of chair of the Asia-Pacific Public Policy Committee that ASMO formed about 6 years ago. And I think one of the reasons for that was about a quarter of ASMO membership is from Asia, and they decided to invest and do these studies. So we engaged a consultancy to help us gather data. And what we found is clearly there's a divide between the countries that have, like high-income countries, and the countries that don't have resources, like low or low-middle income countries. I think this was an important study to give us that baseline, like where we are in terms of healthcare, specifically cancer care in this region. So the first step was that, and now we are in the process of publishing the data. I think some key information I can probably share with you would include things like, countries like India having 1 medical oncologist per million population, while places like Australia has 22 oncologists per million population. Singapore has 30 oncologists per million population. Hong Kong is about the same as well. So there are all these discrepancies and that contribute to challenges that patients face in these countries. Drug excess is a problem. Countries are not investing money. The out-of-pocket costs in countries like Bangladesh or Pakistan is nearly 90% for cancer drugs or more. And as such, most patients there will not be able to afford these therapies. So the next step was to try to build capacity, including leadership. So we run leadership training programs for oncologists, junior oncologists in the region, to give them leadership skills, ability to then use this information, go to their policymakers and try to make some changes there. So some other smaller projects include database projects and a whole bunch of things. But I think one of the key messages I had, and I thought was appropriate for this meeting, was that I feel ANZUP has so much of talent, ability and passion to drive clinical trials that Asia will benefit tremendously if ANZUP could come into the region and help Asia, especially in many countries where we don't have the ability, neither the infrastructure for clinical trials.
Yeah, I mean, that's an excellent point. It's a real call to arms. I think there is a definite need for global oncology and there's an enthusiasm. But more importantly, I'd like to thank you for your being so generous with us, with sharing your wisdom and your time. We've really appreciated it. And thank you very much. And I hope to see you back with ANZUP in Australia very soon.
Thank you. Thank you.